Thank you for joining CBIA and the Office of Health Strategy, or OHS, for this important event highlighting the agency's incredible progress in the last year implementing the Connecticut Healthcare Benchmark Initiative. As the legislative session is wrapping up and major policy considerations are given to improving cost and access to healthcare, the data that OHS will unveil today is critical to ensuring public policy accurately targets the underlying cost of care moving forward. We know that small businesses across the state are continuing to struggle to afford health insurance for their employees. In fact, earlier this year, CBIA surveyed our membership and found that over 97% of CBIA members are very concerned with the rising cost of healthcare. And we made it our mission this year to promote legislation that will make doing business and providing health insurance in Connecticut more accessible and affordable. The information and analysis you will hear today from OHS is a starting point for these public policy considerations, as we cannot improve the rising cost of healthcare until we expose the rising costs of healthcare. So I want to thank Director Veltri and your staff at OHS for making time today for small businesses to learn about the important work your office is doing. CBI will always be a partner with the state government to expose, target, and ultimately lower the rising cost of healthcare. So Vicki, as I mentioned, it's so critical to our members that we do address the healthcare costs, and we look forward to the presentation today.
Thanks so much, Chris. It's great to be here with you. It's great to partner with you on this work. We know at the Office of Health Strategy and through the administration how difficult it is for employers to continue to support increasing healthcare costs and the burden that places on businesses and the ability to locate business in Connecticut and stay in Connecticut. And we consider that as important as any other issue facing our residents in terms of their ability to stay in Connecticut. So we know individual residents struggle to afford healthcare. We know businesses struggle to afford healthcare. And that's why we're here today. We want to continue this partnership. We want to welcome your voices into this work and commit to partnering with you as we move forward on this work. So this will be the first of what I hope will be multiple engagements with CBIA and your member organizations to share progress and get input and answer any questions. So with that, I am going to turn this presentation over to Michael Baylett of Baylett Health. Michael has been, and his organization have been supporting the Office of Health Strategy in this initiative, and as well as other states Michael supports. So we are in this with a group of probably 6 or 7 other states across the country that have taken on this work because we're so committed to the problems we're seeing with the affordability of care. So with that, I'll hand it over to Michael. Michael.
Thank you, Vicki. Good morning, everyone. So within our time together this morning, I'd like to cover the following agenda, introducing and really framing healthcare affordability in Connecticut as an issue, giving some context for OHS's work in this area, which is Executive Order number 5, and then walking through the work that has followed from that executive order, including the cost growth benchmark, but also some other related activities. And both at the end, but also throughout, I want to invite the opportunity for questions. So if you do have questions as I begin to share information, please feel free to share those. So let me start with talking about healthcare affordability in Connecticut and sharing some information with you. So the reason for state health policy focus on healthcare affordability is Connecticut's healthcare spending per citizen is among the highest in the country. It's growing much, much faster than personal income. And the problem is relentless. This is not a short-term problem. It goes on year after year after year. So let me provide some data to support those points 1 and 2. First, healthcare spending in Connecticut, you can see at these 2 measurement points, 2009, 2014, which is the most recent data that we have available. Connecticut's per capita personal healthcare spending was in the top 5 in the country. In terms of growth, you can see here that since 2000, over the last 2 decades, worker contributions to employer-sponsored health insurance has grown 2.5 times the rate of personal income. And that's just the contributions to premiums. The out-of-pocket spending, that is the deductibles, coinsurance, that's growing even faster. This high rate of growth is really compounded by the fact that wages in Connecticut have been growing slower than in most states. You can see that rate right there. So, in very quantitative terms, this is the problem. Of course, there's a human toll as well. And we had a consumer who sits on one of the advisory bodies to OHS recently share at a public meeting how she had to withdraw tens of thousands of dollars out of her IRA during 2020 to cover personal health expenses. So while this is all very quantitative and a little bit detached, there's a human story to all of it. So that's the context for the affordability problem. Now let me talk about Executive Order 5 and all of the work it's engendered. So the governor issued this executive order in January of 2020, 6 weeks before his first executive order for COVID-19. The executive order is really driven 4 separate work streams, and I'm going to talk about them sequentially. A cost growth benchmark, which sets targets for slowing healthcare spending in the state over a 5-year time period, a target for increasing investment in primary care, a strategy for leveraging the state's all-payer claims database to provide more insight into what's going on in healthcare spending, and then a set of quality benchmarks which serve as a complement to the cost growth benchmark. So I'm going to talk through each of these, but first let me share what the process has been for developing policies in these 4 areas. OHS created 2 bodies, one that they call the technical team, which has got state agency representatives and some outside stakeholders, but does not include insurers and does not include providers. And this has been the primary advisory body on the executive order work to OHS over the last year plus. In addition, there's a much larger stakeholder advisory board. It's got 24 members and it's got broad representation, including employer purchasers as participants. And the stakeholder advisory board provides input to the technical team, which then advises OHS. And separate from these 2 bodies, there's been lots of stakeholder engagement, meetings like the one that we're having this morning to share information and to solicit input. These are the members of the technical team. I describe this as sort of a protected group because the vested stakeholders that generate revenue from healthcare are generally speaking not represented here. And so they have the ability to provide some input that's not influenced by personal interests in healthcare spending. And this is the stakeholder advisory board, and Vicki has served as the chair of each of these 2 bodies.
Michael, excuse me for 1 minute. Your microphone went quiet a little bit. We can hear you, but barely.
Okay. All right.
There, much better.
All right. I will make sure I project. Thanks for letting me know, Vicki. Okay. So these are the people who've been providing formal input, but as I noted, there have been additional meetings with all sorts of stakeholders and consumers throughout this process. Okay, so let me now dive into the 4 work streams, the first one being the healthcare cost growth benchmark. So first question is, what is a benchmark? Well, it's a per capita rate of growth target for total healthcare spending within the state. And the reason that this initial group of states has adopted them as a tool to slow cost growth. And the reason for wanting to slow cost growth is really represented, both in the affordability slides that I showed you earlier, but also these 3 boxes. This is data for Connecticut. You can see per capita cost growth. I'm sorry, this is data for the United States. Per capita cost growth has been growing faster than the economy and faster than wages. And that difference repeats itself year after year. That's the problem. So these are the states that are involved in this work. The states in green have established cost growth benchmarks. The states in blue are now working to do so for 2022. And California's got a legislation in process to begin to do this. So the cost growth benchmark really serves as an anchor for a set of other strategies that together should slow healthcare spending growth. So that's why, we're using the metaphor anchor right here. It establishes the public expectation for how fast spending should grow and creates a basis for transparency about healthcare spending growth. Transparency at multiple levels, and not just at the state level, but also at the health insurance market level, the health insurer level, and the large provider entity level. And I'll talk about what I mean by large provider entity later. But in and of itself, it's not sufficient. It has to be complemented by other strategies. So here's the full logic model for the cost growth benchmark. So states set the cost growth benchmark, and then they measure performance against the cost growth benchmark to see whether they are falling below or exceeding the benchmark. They complement this work with analysis to understand where's healthcare spending high and where is it growing fast. And this work is done using the all payer claims database. It's a cost driver analysis. I'll talk about this later. The third element of the logic model is to report performance against the benchmark as well as on these cost growth drivers, so that there's lots of transparency about who's performing well and who isn't, and also what's contributing to healthcare spending and where does accountability lie. From that, there's identification of opportunities to slow healthcare spending growth in the state, and then adoption of strategies that target cost drivers. And this work repeats on an annual basis in an iterative fashion. The benchmark is the anchor in the middle. So let's talk about Connecticut's cost growth target. The technical team, that's the primary advisory body, recommended last year that a benchmark be set linking healthcare spending to the potential gross state product, which is a forecast of the state level GDP and forecast for median income growth in the state. And the technical team recommended, and OHS accepted, that the weighting should be 20% the forecasted state GDP and 80% the forecasted median income. So healthcare spending growth should grow no faster than this weighted calculation. The resulting benchmark was 2.9%, far below what employer healthcare spending has been. The technical team recommended that in the first 2 years, there be a little bump on top of that 2.9%. So for this year, it's 3.4%, which is still significantly below traditional spending growth in the state. It drops to 3.2% next year. And then for the next 3 years, it's 2.9%. So the initial cost growth benchmarks are for 5 years and sloping down over the 5-year time period. This general approach, the methodology for setting the benchmark, is consistent with the other states. There are 8 states total, 5 states have them in place right now, and then 4 plus Pennsylvania working towards them for 2022. So Connecticut is generally in line in terms of its methodology with these other states that you see listed here. So the data for the cost growth benchmark is not collected from the all payer claims database. It's collected directly from payers, and they report the data in aggregate. So it's not claim level data. It's aggregate calculations that follow instructions that have been released to the payers by the state. When I say payers, I mean insurers, to the federal Medicare program and to Medicaid. The reason that payers are the source of the data is it's the only way to get the commercial self-insured market, because the state all payer claims database is broadly lacking self-insured data, except for the state employee health plan. In addition, the all payer claims database is lacking non-claims based data, and it also doesn't have drug rebate data. And so by having the payers report aggregate data, we can get a more comprehensive assessment of healthcare spending in the state. And this is what other states have been doing. The technical team received feedback from the Stakeholder Advisory Board about potential risk of setting a cost growth benchmark resulting in underuse if, say, providers for some reason responded to the cost growth benchmark by limiting access to services. So the technical team recommended a monitoring strategy to detect any underservice, and OHS is implementing that strategy. Okay, you can find the recommended monitoring measures and actually everything about the cost growth benchmark on the OHS website, including materials from the meetings of the technical team and Stakeholder Advisory Board. So you might ask, does this work? So the first state to have done this, that is this being a cost growth benchmark, was Massachusetts. It began this after legislation in 2012. And this diagram right here maps performance in Massachusetts. You can see over the initial year, some years they came in under their benchmark, which was 3.6% through 2017. And a couple of years they were over. In one of the years they were over, actually in both of the years, they judged that being over was justifiable. For example, one of the years was the year that healthcare spending spiked because Sovaldi, the hepatitis C drug, came out. And there was a conclusion that it was worthwhile for a spike in spending that year because Sovaldi essentially eliminated hepatitis C. But you can also see in the most recent year that Massachusetts reported, they were quite a bit above their benchmark. And so while over the first 6 years, healthcare spending averaged at their benchmark, which is now, by the way, at 3.1%, they exceeded quite a bit. And this is giving rise to some reconsideration in Massachusetts, whether they need to apply some stronger consequences for not meeting the benchmark. In Massachusetts, there are no punitive steps taken if a payer or a provider exceeds the benchmark. The state might request a corrective action plan, but that's it. And so now Massachusetts is reconsidering based on the most recent experience. But overall, the experience is suggestive that the benchmark has had some impact. Where the information is more compelling is the impact on commercial spending growth. And this is just correlation, it's not causation, but the correlation is pretty interesting. So this looks at commercial spending growth in Massachusetts. And you can see prior to 2013, which was the first year that their benchmark was effective, Massachusetts commercial spending growth was above the national spending rate every year except for 2009, and way above some years. Beginning in 2013, Massachusetts has been below every year and quite a bit below. This is consistent with our hypothesis that a cost growth benchmark will have the most benefit in the commercial market because Medicare and Medicaid can control price and thus can control spending growth to a significant degree, although not completely. The commercial market has no control over price. And so it appears that in Massachusetts, the cost growth benchmark was a positive force in slowing healthcare spending growth in the state. So I talked earlier about the 4 levels of reporting. I want to go into that a little bit further right now. So in all these other states and planned for Connecticut, reporting will be done at the state level by market. And by market, I mean Medicaid, Medicare, and commercial including both insured and self-insured. And then at the individual insurer level, and then finally at the provider entity level. So you might ask, what's a provider entity? Provider entity is going to be a large health system that consists of hospitals with employed physicians, a large medical group that's got a lot of primary care physicians, an IPA, an independent practice association, again, one that has a lot of primary care physicians, and perhaps some very large federally qualified health centers. And I say large because if there aren't enough patients that are being served by the provider entity, then we can't measure performance with any statistical confidence. So this is only going to be through large entities. It's not going to be imaging centers. It's not going to be pharmacies. It's not going to be orthopedic groups. It's got to be larger entities that have lots of primary care clinicians. Okay, again, consistent with the approaches being taken in the other states. So the next steps for implementation of the cost growth benchmark are laid out on the next slide. So right now, OHS is in the process of gathering data from payers for a pre-benchmark period of 2018 to 2019, so that we'll have a sense of what was healthcare spending growth like in the state before the benchmark and before COVID. And the payers are responsible for submitting data by June. OHS will spend the summer analyzing it, and hopefully by September publicly report what spending looked like. In this case, only at the state and the market level, no insurer and provider entity level reporting for this pre-benchmark, mostly because this amounts with the payers to something of a practice run, and experience in other states shows that they don't always get the data reporting quite right. So for that reason, there's not going to be reporting at the insurer and provider entity level for this first go round, but there will be in the future. I want to note that when we get 2020 data, we know that we're going to see a dip in spending growth because of what happened during COVID, especially in the first 2 quarters of 2020. And we also know we're going to see a little bit of a spike in 2021 because spending was depressed in 2020. Okay. Under Governor Lamont's executive order, there's no punitive action for exceeding the benchmark, similar to Massachusetts. Okay. I'm going to pivot now to the second element of the executive order, and that's the primary care spending target. So why primary care spending target? Well, we know that compared to other developed economy nations, the United States is much more specialist oriented if you look at the distribution of clinicians and of spending. If you look at much of Western Europe and Japan, for example, you will find that the percentage of spending that goes to primary care is much higher, and overall spending is much lower. And research has shown that health systems that are primary care centric have lower spend, higher quality, higher patient satisfaction. So states are trying to address this a couple different ways. One is supporting primary care delivery and in helping practices have tools and capacity to deliver better care. The other way is to reallocate funding so that a bigger share is going to primary care and a smaller share going to hospitals and specialists. And so this next part of the executive order is about increasing the primary care share. So we estimate that right now in Connecticut, about 5% of healthcare spending is going to primary care. The executive order is looking to double that to 10% by 2025. Connecticut is not the first state to do this. Rhode Island was actually the first state, and they did do so. And spending is both lower and growing slower in Rhode Island than in Connecticut. So this increased investment in primary care was not inflationary in Rhode Island. Now, they took some other steps for that to be the case, but I just want to note that. So if we take together the two concepts of the cost growth benchmark and the primary care spend target, you can see that there's a pressure to lower spending growth while increasing the share to primary care. So the real pressure here is on non-primary care to slow spending growth. And as I'll show you later, it's not primary care that's been driving healthcare inflation in Connecticut, it's elsewhere. And I'll show you where a little bit later. Here again, no punitive actions will be taken for payers or providers that don't meet the primary care spending target. So the target for 2021 was set at only 5%. The best estimate that we had was 4.8%, but we didn't have definitive baseline information. And so not having definitive baseline information gave cause for being cautious. Now, that baseline information is being collected as part of the data that's coming in June for the cost growth benchmark. So we will have the baseline information shortly. In addition, we knew that COVID-19 had impacted spending a lot in 2020, and we didn't know if it would in 2021. So OHS was conservative in setting the primary care spending target for 2021. But it clearly is going to have to grow over the next 4 years to get to that 10% in the executive order. Consistent with the cost growth benchmark, reporting will be done at these 4 levels. So this is going to parallel the data collection and reporting process for the cost growth benchmark. Okay, worksheet number 3, quality benchmarks. Quality benchmarks are, as I said earlier, a parallel to the cost growth benchmarks. Their purpose is to maintain and improve the health of Connecticut residents and of the health care delivery in the state. The executive order says they may include these types of measures, but doesn't dictate it. And Connecticut will be the second state to establish quality benchmarks. I think others will follow. But right now, only Delaware has statewide quality benchmarks. The development is the responsibility of another OHS body. It's defined as the Quality Council. They are right now just beginning work on recommendations, and the quality benchmarks per the executive order to become effective January 1st, 2022. And last, the data use strategy. So you might recall in the logic model that I shared with you for the cost growth benchmark, one of the elements of the logic model was to do a deep analysis of cost drivers to understand why spending is growing so that opportunities can be identified and mitigation strategies designed. That's what the data use strategy is all about. So this is utilizing the All Payer Claims Database, the acronym is APCD, with other data sources to get insight into what's driving healthcare spending in the state. The intention is that OHS will then, beginning later in the year, convene stakeholders to talk about what the data mean and identify strategies to target healthcare spending growth. So some initial analysis was done last fall and this past winter to perform an initial analysis. It's not definitive, it's not complete, but it provides some meaningful insight into what's driving healthcare spending. I'm going to share with you just a little bit of that information. There's a lot more that you can access if you have interest, but I want to share with you a little bit of insight into what's driving healthcare spending growth in Connecticut, or at least has been over the last few years. OHS is planning additional analysis later this year and into future years to look at, to develop a deeper understanding of what's happening. So this is healthcare spending growth between 2015 and 2018 in Connecticut. You can see the annual rate, and this is for commercial spending. So this is employer-based coverage plus marketplace coverage. 8.1%, 3.4, 3.2, 15% over 3 years, or an average of 4.9%. Okay, that average of 4.9%, way faster than economic growth and way faster than wage growth. Now this is commercially insured population under 65. It includes the employee share of healthcare spending. So it's got the deductible co-insurance co-payments. Okay, 4.9% a year. If we look at what was the employee share, the out-of-pocket spending, 8%, 13%, 3%. Okay, much, much higher rate of out-of-pocket spending for consumers than overall. And you can see the difference here, 26% over 3 years in out-of-pocket spending compared to 15% for overall spending, right? And why is this happening? Well, you know why. Plan designs have bigger deductibles and more coinsurance, and employees are picking plans that have more deductibles and coinsurance when they have a choice, which they don't always have, but when they do have a choice, they are making that decision to lower the premium contribution growth. So why has it been going so fast? Well, in Connecticut, it's about hospital spending. Hospital spending grew almost 7% a year on average over the 2015-2018 time period. So this is spending, again, we're talking just commercial, so employer-based coverage generally. This is the spending broken down by service category. Professional spending barely grew, 2.7% a year. That's a pretty modest rate of growth. We would love that if that was the rate of growth for total spending, but the hospital spending, super high, 7% a year on average, acute, inpatient, outpatient, not ER, and outpatient ER.
Michael, can you just maybe elucidate a little bit on what professional services are versus?
Yeah, so professional services, those are physician services. It could be behavioral health clinician services, non-physician, physical therapy, all the services delivered by professional providers, so not facilities. Okay, so we know where the problem is, or at least where it was in this time period. It's pretty clear why. So we can look a little bit further to determine, was the issue that people were accessing more services or that we were paying more per unit of service? If you look over here, the volume for hospital services was actually negative. So we had a 4% reduction in inpatient hospital stays over this 4-year time period. We had a -1% reduction for ER and a small increase, 2%, in outpatient services, outpatient hospital payments over this time period. Professional spending, a little bit higher, but certainly not high in terms of utilization over this time period. Okay, so if it's not utilization, it's in spending per unit. And here you can see 10%, 7.4, 7.2% for inpatient hospital per year. Okay, that's the payment per unit of services. We did do a little additional analysis to figure out, so was it the prices or were people getting more intensive services? And about 3/4 of it is price. So there's a little change of mix of services with the inpatient services being more intensive, but it's mostly price. The prices were growing at very high rates over this time period. And this graph right here gives you a depiction of what was going on price and what was going on service utilization. So we had a reduction in utilization over time, but overall spending grew 22%, despite a reduction in utilization. Another example of some insight that was gained through this analysis was looking at prevalence of chronic conditions. And what we can see here is, if you look at all members, $6,000 per member per year spending. If you look at those with one or more of 27 chronic conditions, $10,000 a year. 6,000, 10,000, based on whether you've got a chronic condition. If you have 2 or more chronic conditions, it's 14,000. So over 2 times higher spending for having chronic conditions. Some of these chronic conditions are going to arise simply because of the aging process, but a lot of these are lifestyle related. Hyperlipidemia, that's high cholesterol, right? And diabetes, certainly lifestyle related, hypertension, lifestyle related. And you can see the impact on healthcare spending. So I'm sharing with you just a little snippet of some of the insights that we've already gained through analysis of the all payer claims database in terms of understanding what's driving healthcare spending growth. The next question, of course, is what to do about it. And that's what's essential, because if we set a target and we do analysis, but we don't identify any actions and we don't take any actions, then all this is for naught. And so to wrap up, I want to say that understanding what's going on is a prerequisite to correcting what's going on. So the cost growth benchmark is a beacon that should hopefully help influence action to mitigate rises in healthcare spending growth. We are increasingly understanding why. We will soon understand how it varies across the state. We should know that later this year. And we will also know more definitively what's driving healthcare spending growth beyond the insight that I've shared with you today. So I hope this has been informative and maybe even energizing. And why don't I pause now for some discussion?
Thanks, Michael. And if anybody who's participating in the meeting would like to ask any questions, we would welcome that. Or if you're not comfortable with doing that today, you can always contact us with your questions and ideas, but we really hope to keep you engaged in this work. So at this point, I guess we would welcome any questions right now for anyone who's online and has any. Anyone? Okay, it looks like we have a lot of people listening, but maybe you're not ready to ask a bunch of questions. I will tell you, as this moves forward, I think you're going to probably have more and more questions as we collect the data for this year that we are collecting from the carriers to analyze what we're seeing in this benchmark couple of years. It'll be interesting to analyze these data because it will be a bit of an update on some of the data we just presented to you. And this work requires really participation from all sectors because this has to be a process that we all own and work together on to keep us moving forward. Okay, so there is a question in the chat, actually, or Q&A. How soon, Michael, would we see the possible benefits of this policy apply to medical renewal rates? That's a reference to, I'm sure, your insurance premiums.
Yeah, so I think that the question that we can't answer yet is how are payers and providers going to respond to the benchmark? What we saw in Massachusetts is after the benchmark was established, payers, when they went to negotiate annual contract rate changes, would say to providers, okay, the benchmark is, X point Y%, or for Connecticut, 3.4%. So our expectation is that spending under our contract with you isn't going to grow any more than 3.4%. If payers and providers, especially the big systems that represent a disproportionate amount of spending, begin to negotiate their annual increases around the benchmark, then you would feel the impact a year after the change takes place. The big question right now, though, is whether Connecticut insurers are sitting down at negotiation time and saying the benchmark's 3.4%, and that's our expectation, or not. And so, and we're not going to know that for a little while.
Right, and just a reminder, this is the first implementation year of the benchmark. 2021 is subject to the benchmark.
Yeah.
So,
and I will say, to be fair, the benchmark value wasn't finalized until the fourth quarter of calendar year 2020, which was probably after the 2021 contracts have been negotiated. So to be reasonable, I would hope that the 3.2% benchmark for 2022 would be negotiated into contracts, actually negotiations that are probably starting right now, between payers and providers for 2022. And so when the spending shows up in 2023, it's going to lower the rate. So we're probably at least a couple of years away from you seeing anything on renewal rates. I would suggest to employers that you ask your plan administrators, are you negotiating your contract renewals with providers using the benchmark? Because that's a huge lever. And to the extent that employers are frequently asking their plan administrators, are you negotiating around the benchmark and only increasing payments to the benchmark level, then it's much more likely to have impact and to show up in your renewal rates.
Okay, thank you.
And I want to say that's true for both self-insured employers that have plan administrators. It's also true for insured employers that are buying insured products.
Okay, so that sort of answers a question that was put up here about small businesses having any impact on this process, or is it all based on the bigger ones? And the answer to that is no. You all can have an impact on this process, as Michael just said. If you're in a fully insured arrangement, you can help with this process, right? You could talk to your carriers, you could talk to the people you're working with who are negotiating your plans about the importance of the benchmark and the need to keep the spending under control. I don't know if, Michael, you want to add to that, but there are a few more questions in the Q&A that
I'll share my experience in Oregon. We had a couple of small business CEOs that participated on an advisory board. And every time the provider said, we're major employers in the state, we're creating jobs, the employers responded and said, your healthcare expenditures are taking away jobs from the rest of the economy. And you know, that's a healthy balancing conversation that's important to have in any state.
Okay, so a few questions. With the benchmark set, will this affect how much insurance companies are allowed to charge, especially in the small market where the state dictates the rates? So let me just start by answering that question a little bit. I'm not sure what the reference is to the state dictating the rates. The state approves the rates, or the state reviews the rate filings. I'm not sure they dictate the rates, but nonetheless, I think I understand the intent of the question. So with the benchmark set, will this affect how much insurance companies are allowed to charge, especially in the small market? I think that's sort of been answered in the previous question, but I'll let Michael take a shot at it.
Well, so I'm not sure what the rate review process is, Vicki, in Connecticut.
Yeah, we don't. So I will just put in here that the insurance department is on the technical team and has been very supportive of this initiative and has been championing the initiative as a way for them to see more detail about underlying cost drivers and what goes into the premiums. And so I fully expect that Paul, the insurance department actuaries will be invested in taking these data and considering them in the rate review process. That said, I don't know how that will factor in until we get these data presented to us, but I do know the insurance department has a deep commitment to the work.
Yeah, I mean, I would say if spending growth rates come down, then when the insurers file their rates, they should be filing their rates based on their spending experience. And if the spending rate is down, then the rate shouldn't grow as much.
Right. So that's I think the deep interest that the insurance department has in the process is comparing what's filed in the SURF system, which is the rate filing system, with the data that we're seeing. And I think that's going to be important for them to look at. If no punitive action, what's the incentive? I can take a shot at that, or you can.
Whatever you prefer, Vicki.
Well, I think, first of all, the transparency is something that we have seen has already led to some action in some states. Michael could talk about what's going on in Rhode Island with some of the recommendations they've made. I think the incentive is pressure with transparency at this point. The executive order really does not include any kind of punitive measure at this point. We were hoping to get people around the table to see what's really going on, because a lot of the discussion has been, quite frankly, a lot of finger pointing across the system at who's who's the real driver of healthcare costs. And this benchmark activity gives us the actual chance to see what the drivers are and talk to people about them and try to drive policy making through the transparency initiative. But I'll let Michael contribute more based on.
Yeah, I'll say from my experience, payers and providers, especially providers, really care about whether they're going to be called out publicly for not hitting a public cost growth benchmark. And the more effective the state is in making the benchmark high profile and making all stakeholders aware of it, the more they don't want to be painted as a bad guy for not hitting the benchmark. I will say that when Massachusetts passed its legislation in 2012, I was highly skeptical that it was going to have any impact because there were no sanctions for exceeding it. And yet it appears to have had some impact. So I have some measure of optimism. It may be necessary that someday it's necessary for there to be some consequences, but I'd say the experience from Massachusetts on what I'll describe as aggressive transparency is pretty hopeful.
Yeah, and we can also, I think, give a little bit of a hint at Rhode Island. You know, Michael works with Rhode Island as well, and they've seen some of their data. Just based on their data, they're undertaking initiatives or recommending initiatives that the state take to try to contain some of the increasing costs based on the data they're collecting. That's the kind of work we hope to do moving forward with stakeholders around the table. We have committed to this being a collaborative process. We want it to be collaborative. That means all parties need to come to the table and sort of own the issue that we're seeing, which is increased costs at a rate that are unsustainable, and then drive policy based on the data that we're seeing. So we anticipate that we will be doing what Rhode Island does, or Rhode Island has already done, which is, I think, recommended at least one initiative based on the data they've seen. And we'll be doing that moving forward as well. So there's another question here. Since the benchmark is also based on income, wouldn't the increase in the minimum wage translate in a decreased number compared to the benchmark, and therefore allowing the insurance company to increase their premiums?
Well, so I don't totally follow that, but I want to note that the technical team doing the 2080 weighting was really trying to find a basis for setting the benchmark value, and it's for 5 years. And so if the minimum wage goes up and median income goes up over the 5 years, the benchmarks aren't going to change. They're set for 5 years. In year 4, OHS will ask the technical team or some other stakeholder body to weigh in, but the linkage between median income and the benchmark is not direct, meaning it doesn't change over time as those indicators change. And I will note that benchmark value of 2.9%, that's, I forget exactly, but that's around 60% of the rate of growth over the last 20 years in Connecticut. So it represents a significant slowdown in spending growth over what has been occurring, and frankly, what I would expect would otherwise be occurring if not for any action.
Okay. And that seems to, we don't have any current questions in the Q&A. If anybody has any additional questions, please feel free to pop them in. We're happy to answer them. I think if we wait a minute and we don't see any, we may be able to conclude our event. I appreciate those questions. I think those are all the kinds of questions we've been getting. They're similar to other questions we've gotten. But please make sure you follow this effort as we go forward. We'll continue to work with CBIA to give Wyatt and the team and Chris continued updates and try to come back and meet with this group. We'd also encourage you offline, if you have questions, to let us know, and we'll be happy to answer them. Or if you have other people you think we should engage with, if we're missing an audience that we haven't been in front of to talk about this effort, and you think there's someone you can recommend that we speak with or a group we speak with, we'd appreciate that recommendation as well. With that, I'm not sure we're going to get any more questions. Go ahead, Michael.
Yeah, I just want to add, the cost growth benchmark benefits employers and employees more than any other stakeholder in the state.
Mhm.
And it would be great if CBIA and its members became stout advocates and supporters for the strategy, because those sectors of the economy that would like to see healthcare spending grow will not be as enthusiastic at times about this work. And having your voices be present will be important to the success of the strategy.
That is absolutely true. And I also want to say from the seat I sit at, the governor has talked quite frequently about healthcare costs increases and the effects on businesses, especially the small group market, what we've seen going on in the small group market. And we know a lot of CBI members are in that market and are facing increased insurance premiums that are a reflection of the underlying costs that drive them. So your engagement in this work and your support, or whatever support you can offer us, I think is very helpful to this work, and the continued messaging about the need for the state to take on a strategy like this is critical for us moving forward. So we appreciate the time you'd offered us today. I will thank Chris and Wyatt and Molly, the team at CBIA, who have put this together for us. And we will be happy to be back, probably after we release the information in late summer or early fall about the data that we will have collected over the summertime. So I want to thank you all again for participating. I want to thank Michael, and just welcome you all to continue engaging with us as we move forward. Thank you very much. Take care, everybody.